will be presenting this diabetes. Mrs. X, 36-year-old, residing in Tilnamikari, housewife, belonging to lower middle class. Date of admission 25/11/2024. Date of examination 26/11/2024. Came to the gynaecology with the chief complaints of heavy menstrual bleeding for past 5 months, pain during menstruation for 5 months, history of present illness. The patient was apparently normal 5 months back. Then she had complaints of heavy menstrual bleeding, which is 6 to 7 days per regular 20 days cycle, so 6 to 9 pads per day, associated with passage of medium cycle clots and passport dysmenorrhea, and history of vaginal discharge for past 3 months, white in color and not associated with photosensitive and itching, history of generalized tiredness for past 2 months, history of restlessness on walking 10 steps for past 2 months, history of palpitation present for past 2 months, history of increased frequency of urine for past 2 months, no history of urinary obstruction, no history of dyspareunia, no history of intermenstrual or postcoital bleeding, no history of mass descending per vagina, no history of mass per abdomen, no history of fever, no history of loss of weight, appetite, early satiety, no history of bowel disturbance. Menstrual history: patient attained menarche at 13 years of age, LFP 28/10/2024. Previous menstrual history: cycle at 28 days, duration 3 to 4 days, number of pads used 2 to 3 per day, absence of loss and no dysmenorrhea. Present menstrual history: cycle at 28 days, duration 6 to 7 days, number of pads used 6 to 9 per day, clots present and passport dysmenorrhea present. Marital history: married at 23 years, not consensual marriage. Obstetrics history: obstetric code P3L2A1B1, last childbirth 5 years ago, para at 24 years, 2012 LSCS at Tinelary Medical College Hospital, male baby, weight 4 kg, alive and well. Para at 25 years, in 2013 LSCS at Tinelary Medical College Hospital, male baby, weight 3.4 kg, died at day 1. Para 3 at 31 years, in 2018 spontaneous abortion at 2nd month and dilatation and purity normal. Para 4 at 32 years, in 2019 LSCS and postpartum sterilization done at Stimoha Hospital, female baby, weight 3.4 kg, alive and well. Past history: she is not a known case of type 2 diabetes mellitus, hypertension, tuberculosis, asthma, epilepsy, thyroid, cardiac and renal disease. No history of blood transfusion in the past. Surgical history: in 2012 LSCS at Tinelary Medical College Hospital, 2013 LSCS at Tinelary Medical College Hospital, 2019 LSCS and sterilization done at Stimoha Hospital. Drug allergy history: no history of any drug allergy. Family history: no history of any cancer in the family. Personal history: missed diet, sleep adequate, normal bowel and bladder habit, appetite normal, no history of any addiction. General examination: the patient is conscious, oriented to type patient person and moderately built and nourished. Height 168 cm, weight 86 kg, BMI 13.47 kg per square meter, and grade 2 pallor present. No interest, no sinuses, no cupping, no lymphadenopathy, no pedal edema, bilateral breast examination normal, thyroid examination normal. Vital pulse 1 or 2 beats per minute, blood pressure 130/70 mercury, respiratory rate 20 plus per minute, temperature 80 systemic examination, cardiovascular system S1 S2 here, no numbers, respiratory system normal vesicular background, no aerosol, central nervous system no neurological deficit present.
Now I will be continuing with examination. On abdominal examination, in inspection, abdomen is locally distended, umbilicus is midline and inverted, all quadrants moves with respiration, a healthy LSCS scar present in suprapubic region, no sinuses or dilated veins, and hernial orifice is intact. On palpation, abdomen is soft and non-tender. An irregular firm mass of 14 week size uterus occupying umbilical and left iliac region, side-to-side mobility present, no guarding and rigidity. On percussion, dull note is heard over the mass, auscultation, bubble sounds heard. Then coming to gynecological examination. On perspeculum examination, vaginal mucosa pallor present, copious mucoid discharge present, a pale nodular firm mass of 3 to 3 cm felt protruding out of the cervical os, not bleeds on touch. Ballooning of cervix present and cervix appears healthy. On bimanual pelvic examination, a palpable mass of 14 week size, firm in consistency with uterine mobility transmitted to the mass, left fornix fullness present, pouch of Douglas fullness present, no cervical motion or cornicial tenderness. On perectal examination, rectal mucosa free and parametrium free. Summary: 36-year-old P2L2 A1 D1 both LSES with complaints of heavy menstrual bleeding, history of white discharge per vagina and breathlessness associated with palpitation. On examination, pallor present, a mass of 14 week size uterus, palpated per abdomen, firm in consistency, and a nodular mass of 3 to 3 cm protruding out of cervical os. Diagnosis: it is a case of abnormal uterine bleeding with moderate anemia for further evaluation. My differential diagnoses are it can be fibroid, polyp, adenomyosis or ovarian mass. Then these are the relevant investigation.
So how does this initial demographic detail is going to help you in making a diagnosis? This is a general question. How this demographic detail is going to help you in making your diagnosis? Age. What does age suggest?
A reproductive age group has reproductive age some diseases are common.
So now you have to recall. AUB will occur in a reproductive age group. Otherwise, it will be a pre-pubertal or a post-menopausal bleeding. Right? Next, any importance out of your demographic profile, where do you think it is very important, relevant to your case?
Socioeconomic status.
How does socioeconomic status?
High socioeconomic status, PCOS, obesity, endometriosis.
Is it so?
Yeah, in lower economic status, tuberculosis and infections.
In your case? So as such, if I am talking of a demographic profile, age is relevant, rest of the contents are important when we are going to deal with the antenatal cases. The socioeconomic status will help you just what type of management suits her. Rest is not important as such in a gynecological case. Next. Okay. Next. What do you mean by HND? So what is normal? She is having a 28 days cycle. She is having within 7 days. So how it becomes a HND? Fully soaked pads make it that it is HND. Passage of clots. So passage of clots, patient's own perception. I told you the menstrual cycle has to be written in a C drive, right? C drive. So amount of bleeding is always a subjective which is taken as a patient's perception. If she says it is heavy, you also have to decide whether it is heavy or not. So passage of clots is a very important factor. Number of pads is a very important factor, and the third factor which is associated with it is that she is developing anemia. Right? Okay. What else? Okay, you have written history of vaginal discharge. Everywhere you are telling history of vaginal discharge, Okay. So discharge is not that simple. Discharge is not that simple. You have to tell many negative histories in a vaginal discharge. Because gynae just have a discharge and a bleeding. These are the two main nuclei. These are the 2-3 complaints on which we go round. So this is not general. History of generalized. Okay, next. Increased frequency of maturation has not been elaborated. What do you mean by increased frequency of maturation? When do we call it as an increased frequency of maturation? Yes? Pressure symptoms? Is it so? Anyone? What do you mean by increased frequency of maturation? Frequency, that means you need to quantify. Once you are quantifying, it is 1 time, 2 time, 3 time, what time? 2 times might be less for you, 2 times is more for somebody else. So, how do you quantify? How do you say increased frequency of maturation? PGC. Nighttime maturation is called as nocturia. When do you call it as a nocturia? More than 1 time in a night is a nocturia. What is increased frequency of maturation? It's still a very common complaint which you write down. What is increased frequency of maturation? Daytime? Yes. More than 7 times in a day is a increased frequency of maturation. So did you ask? She was having a more than this? So number of times she is going, you have to ask. And every time, how much? Because this is a very relevant history which you need to cast to your patient. Your patient is having a heavy menstrual bleeding. What can be the differential diagnosis on the basis of history of HMV? Now we don't go to the examination. Differential diagnosis of HMV in a 37-year-old female who is a multiplex. DD. Number 1 point. Fibroids. Adenomyosis. Malignancy. So you can say punctoid, simply punctoid, but I don't want for this patient 37 years. So now tell me what you can exclude and what you should have excluded, which is not there in your negative history. Polyp, she have? Okay, she can have a polyp, but what negative history she has given that she cannot have a polyp? Intermenstrual bleeding, she doesn't have it. So can you exclude? Usko niche le aaya. Always in future also when you are doing your practice, lumpy, whatever long PD you have to rotate it upside down. What can come first? So the polyp cannot come up. Next, adenomyosis, punctoid, P is for polyp, A is for adenomyosis. What is a positive finding in your case regarding adenomyosis? Dysmenorrhea. Very good. Reproductive age group female, 37 years, having HMV, developed dysmenorrhea, dyspareunia, she doesn't have. Or you have not taken the history. Pakka. Okay, chalo. So dysmenorrhea, she has. So adenomyosis, abhi we have a first diagnosis. Next, L, can she have leomyoma? Yes, of course she can have a leomyoma on the basis of her history. What else? M, malignancy? Not necessarily. Not necessarily. Now, what are the points I can put in for the malignancy in this case? She is prone for that. Endometrial carcinoma generally occurs in an obese female, that is called as corpus cancellosum syndrome, right? Obesity, diabetes. Can she have a diabetes? Why? Please just tell me the time because I can go on and so on. BMI number 1, number 2? Yes, ma'am. So, you see, the clinician, such experienced clinician can tell you 4 kg baby, second is stillbirth and third. Look at the obstetrical history. First 4 kg baby, second died, and third again, previous 2 LSCS, that's why it has been done cesarean, might be done early, but none of the babies were less than 3 kgs, 3.4, 4 kg. So why can't she be hard today? See, polyuria, polydipsia, polyphagia are the last to come into picture. When the only A1C is 10, then it will come. So this patient could be harboring a diabetes, obesity, HMV. Why can't she have endometrial carcinoma? Why can't she have endometrial hyperplasia? And that hyperplasia could be atypical one. Got it? So your lady has totally changed now. Now we come to point. You will probably ask the management in this case. Only here the definitions will go on in your Bible. Coin. What is the full form for the coin? Coagulopathy. What negative history you have taken to exclude the coagulopathy in your case? Is it there? It's not there. And for PTs, there are 5 points which need to be asked for the coagulopathy, especially related to the ABP. Go back and see. I'm not going into the details of that, right? So coagulopathy not excluded. Now, excellent, excellent, very good. Now comes the ovulatory. Can it be? Why no? Why no? Young female, 37, ovulating female, why can't she have ovulatory dysfunction? She can have. Okay? Next point. Endometrial component? Yes, she can have. Why no? She is having UTI symptoms. She is having an HMV. Why can't she have a component of endometritis in her case? Why can't she be a case of chronic endometritis? Why can't she be a case of tubercular endometritis? Dysmenorrhea is there. It can happen in period. Is it? Isn't it? She has some confusion. Any queries? I am here only to just stimulate your neurons. I can't teach you the subject. For that you have very experienced teachers. I am just here to stimulate your neurons and go back. Okay? So this way you have to think. So E can be there. Can ayurvedic? Did she take the history of ayurvedic? Did she take medication history? Where is the medication history? Where is the medication history? There is no history of medication. Medication. Why can't she have any other hormonal treatment? Or any treatment which can lead to coagulopathy? So there is no history of medication which can cause the coagulation disorder. She is a obese female. Why can't she be hypertensive? Okay? So, actinic has not been excluded. And not otherwise is specified. बना सकते हैं? Can we make it? Yes, why not? Till we make a diagnosis, we can make it as an advice. Do you know what is ABD matrix? First line, first and a half line. What is ABD matrix? This is for you. Go back and read. what is AUV matrix, how you have to make it, how many columns, how many rows you have to form, what you have to write down, what is present, what is not present, and what is you have not investigated. So that is for the PGs, you don't have to go into the detail of the AUV matrix. So now, by the basis of the history, what is your diagnosis? Anything, the AUV, NOS or other evaluation. Can it be called as DUV? No, this word past term should not be used. There is nothing. Okay? If this history would have been of 2 months, can you label it as a AUV? Why? Why? AUV means not acute. Abnormal uterine bleeding. Patient has a history of heavy menstrual bleeding for last 2 months. Past 3 months in case of regular cycles and for past 6 months in cases of irregular cycles. Minimum 3 cycles need to be covered to label it under the umbrella of AUV. Got my point? Right. Now coming to your examination. Go back. So you understood? Yes. Wait here. So you saw he had one abortion also. This history is not complete. And you have written postpartum sterilization. Whenever you are writing down the MSCS, you will write MSCS with dilation or sterilization, not a word postpartum. That is specifically used whenever we are doing in a vaginal delivery cases. Then we write down PPS. Otherwise, it is MSCS with dilation or sterilization. Postpartum word needs not to be used because that is not a separate surgery which you are doing. Got? What is the technique which we use for the dilation? Modified complex technique. Okay. Go further. Okay, here this has been done. Right, very nicely you have elaborated. See, once you are telling me the pulse rate of 102 and in the CVS I just explained this to normal, why not some type of murmur, why not a tachycardia has been especially mentioned in the CVS examination. So you should have written. See, for MBBS we got just a history and the perfect examination. And even in gynecology the perfect history, not even an examination. Because findings to be there are a lot of caveats in the examination. Who has prepared this case? So you meet me after this. I am not going to tell them what are the mistakes in this. Okay? So go further. Go further. T. Wait here. I think seniors will agree with me. Abdomen totally distended in a 14 weeks, 30 BMI. How can it be possible? You have given the findings or they have done? PA given by the right. 14 weeks, even a pregnant female can be or sometimes it's just available. So how can it be that baby with a BMI of 30 locally distended abdomen? Not possible. Got my point? Not your mistake, their mistake. Okay? So always remember 14 weeks generally in a obese female. You cannot look, you can therapy, but inspection not possible. Multiparous females, whole abdominal fat is there. How can you see the bulge? In that even 20 weeks will not be visible. Got it? So umbilicus, this is okay. LSCS scar. For a scar, how do you say it is healthy? Not tender. Do you think this scar after 3, 5 years, 10 years is still tender? Whosoever has Got my point? Very nice. Okay, what hydral orifices we wanted to examine in this case? Yes? What hydral orifices we wanted to examine in this case? Umbilicus, perfect. Anything else? Incisional hernia. And number 5? Femoral neck. If you write down the hernia size, umbilical, inguinal, and this one 3 LSCs. You see? So incisional hernia. This is a viral question, a very favorite question of examiner of my type. And I only ask these things. Next. So, abdomen soft, non-tender, irregular. Now, how can you feel irregularity in a 14-week size mass, which is 14 weeks? That means just palpable one. Irregularity. Occupying umbilical. You have to umbilical. Now, if something is reaching umbilical, how much can be the size? Minimum 20 week size. So it cannot be there. Right? So this should come into your mind that the findings which I got, something a mess is there, you got a finding of some other case. So 14 weeks, so irregular, firm, mass, whatever has been written umbilical, it cannot be there. Umbilical, if it is reaching up to umbilical, it has to be 20-24 week size. Next. So now, okay, I am not going into the detail. Now you have one. Well, I am not going into the detail because these findings are again going to mess you up. We will go back. Now the diagnosis after examination, fast. We will go fast. Always remember, if you are just feeling a suprapubic mass and you think it is a fibroid, you will just call it as a leiomyoma. But if there is a AUB present, you will write it as a AUB-L. Got it? If it is a polyp, which somebody has written something coming out through as, say AUB-P. So complete diagnosis will be there. Okay. These findings are wrong, so I am not going into the detail. We will go further. So you made a first diagnosis because your uterus size was 14 weeks, right? AUBL. So what? Why L? You are suspecting more L, not A. Still uterus is 14 week size. No. A very important point you have written in favor of L. Irregular. Irregular. Suprapubic mass, DD, we have discussed in the morning, right? So I am not going into the detail, but because it is irregular, that means this patient might be harboring what? Multiple fibroids. Multiple fibroids, most probably. ठीक है? अगर regular होता, then differential could have been what? Adenomyosis, polyp, leiomyoma, hematometra, pyometra, endometrial carcinoma, suprapubic mass, whatever TB is there. Right? A, U, B, L, U, beta diagnosis. Now this patient is having a pain where the leiomyoma can have a pain. Last one. Yes. Where L can have a pain. L, lady can have a pain. L, leiomyoma can have a pain. Is leiomyoma painful? ये तो PGs ने बोल दिया मेरे से पेन, तो if you told that leiomyoma is painful, तो it is not painful, but if is a PG question which you have answered. Dr. Disha will give you a job. Right? So, you should be knowing the differential diagnosis of a pain in a neuromyoma. And now, one more condition where the patient will have a pain in a neuromyoma, which nobody told me. Whenever it is some people's thyroid, uterus wants to propel it out. Okay? So then also the patient can have a pain. Now, the next question of the examiner will be, why a neuromyoma can have HNV? Is it necessary? Is it not necessary? What are the causes of the HNV in the case of leiomyoma?
Increase surface area,
Increase surface area, increase vascularity, pelvic condition, okay? Inadequate uterine contraction or what makes a disturbed uterine contractility? Disturbance in the local inflammatory markers, endometrial and myometrial hyperplasia. ठीक है ना? So all these are the causes of HNV. Right? 37-year-old. What are the final? How many minutes? Done? Done. So what are the investigation needs and we will end?
complete blood count,
What for?
ultrasound,
What for complete blood count?
to rule out anemia,
Rule out anemia तो बन गया अगर if the laboratory investigation has not given anemia, that means lab is not send the sample somewhere else. You have to be a clinician who is not dependent upon the investigations. Yes. So anemia you want to rule out. What else investigation you would like to send in your case? Ultrasound. Very basic investigation. And now I will ask you what ultrasound? TAS. Perfect answer. TAS because the uterus is 14 weeks. So you will go for a TAS. If it would have been less than 12 or 10 week size, then we would have gone for a TPS for the better delineation and the differentiation between adenomyosis, size, location, all those things. Any else investigation? TS is very important because simultaneously HNV because of that also. What else?
Doppler,
What for?
to differentiate fibroid and adenomas.
No, we don't need a Doppler to differentiate. What is the criteria for adenomyosis by the way? What is that called as? Musa pair. So Musa criteria is there. How many points are there? And how many has to be present to make a diagnosis of adenomyosis? 8 criteria, 3 should be present. Right. Endometrial biopsy, you can go for it. Endometrial biopsy to rule out carcinoma because your patient fits into the corpus cancer syndrome. Tick. Okay. Management. Fibroid uterus. Myomectomy. Because age is 37 years, you want to retain uterus, but madam wants to go for a hysterectomy. And she's adamant on that she will go for a hysterectomy, she will not listen to you and me. Last question. Leaving it, just